I'm Ernest Choy, Professor of Rheumatology at Cardiff University. I'd like to welcome all of you to today's webcast on biopsychosocial management of persistent pain. These are my disclosures. Although we have lots of treatment for patients with inflammatory arthritis, one of the greatest unmet medical needs is how to manage these patients with persistent pain. This recent publication in Rheumatology Oxford illustrates the size of the problem. It took 3 cohorts of patients across Europe and in UK, examining patients who are in remission and compare those patients who are in near remission. So by and large, many of these patients, their disease are reasonably well controlled, but you can see that the scale of pain, in fact, impaired their physical functionality and impacts on their quality of life. So we know that whilst we can get inflammation down to close to remission level, many of our patients still suffer from persistent pain that is having a significant impact on their disability. A number of years ago, we tried to examine the issue of pain in patients with rheumatoid arthritis. We took a rather different approach, not only asking patients how much pain they have, but actually measure what we call the pressure pain threshold. We use an algometer to measure how much pressure needs to be applied over the skin to elicit a pain response, and we deliberately did it away from the inflamed joint over the scapula. This slide summarizes our finding. On the red line is what we expect the normal population to experience, the normal pressure pain threshold being 400 kilopascal. You can see that in the majority of patients with rheumatoid arthritis, their pressure pain threshold is significantly reduced compared to the population. What this means is that the patient with reduced pressure pain threshold also are more likely to have more severe pain. They're also more likely to be fatigued. They have greater evaluation of the disease activity, have more tender joint and more disability as measured by the HAQ score. What was interesting is that we find that there was a relationship between reduced pressure pain threshold and disease duration, as well as the number of fibromyalgic tender points. And you can see that patients with reduced pressure pain threshold are more likely to have fibromyalgic tender points. But interestingly, there are also patients who are more likely to have longer durations of rheumatoid arthritis. What we find is that if we use multivariate analysis to look at the impact of the tender points and disease duration and the magnitude of pain on the reduced pressure pain threshold, what we found was that both disease duration and the number of tender points were independent predictors of whether these patients will have reduced pressure pain threshold. In fact, disease duration seems to relate positively or negatively with the reduced pressure pain threshold, so that patients with the longer disease duration are far more likely to have reduced pressure pain threshold. So what does this mean? To understand what it means, we need to understand that pain is not a single measurement. Pain has many different categories. We can categorize pain into acute or chronic pain by the disease duration. But more importantly, we can characterize pain by the nature of pain. If we talk to pain specialists, they would typically characterize pain into either inflammatory, which is what happened in patients with rheumatoid arthritis, nociceptive, which maybe was typically occurring in patients with osteoarthritis, or neuropathic pain. Neuropathic pain, by definition, is a type of pain that is caused by a disorder in the neurological system. It can either be a disorder that occurs in the peripheral nervous system or in the central nervous system. For the peripheral neuropathic pain symptoms, the typical example will be someone who suffers from sciatica. The pressure on the sciatic nerve causes pain arising from the nerve endings. Alternatively, there are central neuropathic pain syndromes in which the disorder may be arising from the central nervous system, either in the spinal cord or in the brain. A validated way to determine whether a patient has neuropathic pain is to use this questionnaire called Pain Detect. It is used extensively in assessing patients with, for example, diabetic painful neuropathy, which is a classic form of peripheral neuropathic pain syndrome, or sciatica. Now, if we use a neuropathic pain questionnaire such as the Pain Detect in patients with rheumatoid arthritis, what we found was that a significant proportion of patients will have definitely neuropathic-like pain or probable neuropathic pain. This study I quoted on this slide showed that 17% of patients with rheumatoid arthritis have neuropathic-like pain, and in fact 21% of the patients have probable neuropathic pain. You can see that patients with probable neuropathic pain and a neuropathic-like pain are more likely to have higher pain score. In fact, these patients' neuropathic pain score, as conducted by the Pain Detect score, correlated very strongly with the VAS pain scales. So what this means is that in the proportion or significant proportion of patients with rheumatoid arthritis, the pain is not just inflammatory, but may well have a neuropathic-like component. And this neuropathic component is driving some of the persistent high pain score in these patients. So this leads to a significant questions. Neuropathic pain has been described in patients with fibromyalgia. In fact, some of the characteristics of the symptoms in patients with fibromyalgia has raised these questions. Is fibromyalgia really a neuropathic pain syndrome, as this review illustrates? Well, one thing we do know is that fibromyalgia is not uncommon in patients with autoimmune disease. This slide shows various surveys that have examined the prevalence of fibromyalgia in patients with different rheumatic diseases. In rheumatoid arthritis, the presence of fibromyalgia has been quoted at between 12 to 20%. In systemic lupus erythematosus, from 5 to 25%. In ankylosing spondylitis, between 10 to 50%. And in osteoarthritis, about 11%. And this compared with the prevalence of fibromyalgia in the normal population at 2%, show a significantly higher prevalence of fibromyalgia-like syndrome in our patients with autoimmune diseases. Perhaps this is the reason why we are seeing such high persistent pain score in our patients with inflammatory arthritis. The other supporting evidence for this is that in fact there is a strong relationship between pain and fatigue and depression. After all, fatigue and depression are also common symptoms in patients with fibromyalgia. This is a study that we have done a number of years ago looking at the fatigue score in patients with rheumatoid arthritis. And you can see on this slide is that many patients with rheumatoid arthritis have very high fatigue score. And in fact, fatigue has a multi-dimensional cause in patients with rheumatoid arthritis. Inflammation can certainly drive fatigue through the production of cytokines and impacting on the hypothalamic pituitary adrenal axis. So we noticed that many anti-inflammatory treatments, such as our biologic agents, are able to reduce fatigue. However, fatigue rarely returns to normal, even though the patient has achieved significant involvement. And this schema that was published in Rheumatology Oxford a number of years ago showed that there are many other possible causes of fatigue in our patients with rheumatoid arthritis. Now, the fatigue is not only affected by systemic inflammation, is illustrated by this slide. So if we correlate the fatigue score with the degree of inflammation as measured by the ESR, there was a very weak correlation at about 0.2. It has a higher correlation with the disease activity score, but you can see that the highest correlation actually is with the pain score and in fact with the patient global assessment of disease activity. Going to depression now, we know that depression is highly prevalent in our patients with rheumatoid arthritis. There is a relationship between depression and disease activity, as illustrated by this study from Japan, showing that level of CRP in patients with rheumatoid arthritis correlated with the degree of depression as measured by the back depression inventory. One of the things that confound our measurement and assessing disease activity in rheumatoid arthritis has been highlighted by this study, comparing patients who have concomitant fibromyalgia with patients who don't have fibromyalgia. And in common and with our finding of fatigue in our study, what this study showed was that patients with fibromyalgia are far more likely to have higher disease activity score as measured by the DAS-28 or the Clinical Disease Activity Index. So how can we manage these patients who have fibromyalgia-like disease in patients with inflammatory arthritis? One of the most important things is to consider what the EULAR has recommended for the management of fibromyalgia. First of all, we need to recognize this patient and recognize the fact that their pain is more severe than the inflammation would suggest. The optimal management of this patient will include to assess not only the fatigue but the mental health. Do they have significant depression at the time when they're complaining of very severe pain? Once you have established that they may have fibromyalgia-like syndrome or concomitant fibromyalgia, then you need to consider the impact of this illness on the overall quality of life as well as management. You may need to add treatment of fibromyalgia to the treatment of rheumatoid arthritis. It is also important to recognize that even if the patient have fibromyalgia, they may have different impact on the disease, and the management may well need to be adjusted accordingly. Some patients with fibromyalgia have very high depression burden, while others don't, and these patients may well need to be treated differently. In the EULAR recommendation, it highlighted that in patients with very high level of depression and less able to cope and show signs of catastrophizing, these patients may need referral to specialists, and psychopharmacological treatment is probably more appropriate for these patients. While for other patients who don't have significant depression but have severe pain and perhaps sleep disturbances, a range of other treatment modality may be appropriate. These are the specific recommendations by EULAR for the management of fibromyalgia-like pain using non-pharmacological treatment. And in general, many of these treatments should be considered first before we employ pharmacological treatment. And these include education, exercise, cognitive behavioral therapy, mindfulness, and meditative therapy. All this can contribute significant treatment of the patient's symptoms without interfering with the patient's pharmacological treatment, including biologic therapies. So in summary, musculoskeletal disease are the most common cause of chronic pain in the world. There's a mixture of inflammatory, nociceptive, and neuropathic pain in many rheumatological conditions. In many patients, central sensitization resulting in neuropathic pain, such as fibromyalgia, is common, and we need to recognize these patients in their management in order to improve their overall health. And just treating the patients for their rheumatoid arthritis is unlikely to reduce their pain to the normal level. In addition to pharmacological treatment, there are many non-pharmacological treatments that are available, and this can be used as adjunctive therapy for these patients. Thank you very much for your attention, and I look forward to your questions for this session. Now we have some questions that have come in already. So the first one is, how can one distinguish different kind of pain in clinical practice? Well, that is a very practical question and an important one. I think the most simple way of explaining that to you would be to think about the different kind of rheumatic conditions that we have. So I think people are familiar with osteoarthritis and rheumatoid arthritis. Osteoarthritis is considered as a mechanical disease and therefore typically gives rise to nociceptive pain. So the pain tends to be worse after activity and improve with rest. While inflammatory pain arisen from disease such as rheumatoid arthritis will be typically worse after a period of rest and improve with activity. For neuropathic pain, if you consider symptoms from patients with sciatica, then the pain is typically shooting, often associated with neurological like symptoms. Patient may have paresthesias, tingling sensation. They may consider that the pain is associated like a very hot temperature, and those are typical clinical features associated with neuropathic pain. The second question is, why is it important to recognize chronic persistent pain? Well, the issue really is that in chronic pain, we need to have an adaptive system to manage the pain. Everybody understands the importance of acute pain in protecting our joints and tissue. So individuals who can't feel pain will end up having destroyed joint, typically Charcot's joint. In chronic pain, not only there is the pathway conducting pain to the brain for it to be interpreted, but the brain actually sends down signal from the brain to control or manage the pain. So there's a dynamic process between what we call pain facilitation and then pain inhibition to help us to cope with the pain. So in chronic pain is the balance between these two pathways that ends up in what we call the clinical phenotype. And in managing this condition, what we are trying to do is to reduce the level of pain that gets to the brain, or we can increase the coping mechanism to help the patient to manage the pain. And that's a very different concept from acute pain. The third question is, do you like the University of Michigan's resource Fibro Guide for fibromyalgia patients? Well, I have to say that I admire the work of Dan Claw, who have done those work in the University of Michigan. I think they're enormously helpful for patients to understand what fibromyalgia is, what chronic pain is, and I would certainly recommend it to my patients. The next question is, how available are non-pharmacological management options? Well, for some of them, they're readily available, I think. Exercise in general, although we need to explain to patients that exercise don't damage the joints or tissues. When we talk about mindfulness therapy, these are now widely available. In fact, the use of mindfulness to cope with stress has been taught in many schools in the UK. In Wales, we work with a school of mindfulness in Swansea University, who taught many of our rheumatic patients mindfulness treatment to manage to cope with their chronic painful conditions. Cognitive behavioral therapy is more problematic. Ideally, we would want to have clinical psychologists to deliver this therapy, but recently we have worked with clinical psychologists to train our healthcare professional to deliver cognitive behavioral therapy too. So the availability of these non-pharmacological management options may vary from region to regions, but they are available in different forms in different parts of the country. The next question is, can you share your thoughts on delivery of mindfulness technique? Who, when, and where? Well, let me first explain what mindfulness is. I think it's a technique that helps us to relax and help us to cope with many stressful conditions. Many people with mental health problems as well as rheumatic conditions has benefited from mindfulness therapy. It's definitely harmless. That's one of its major advantages. And in fact, I know that there are many schools in the UK who are using mindfulness therapy to teach the students to cope with academic stress. There are many available resources for mindfulness. There are mindfulness schools, and in fact there are mindfulness therapy techniques available on the internet. one can search them out and they are readily available. Next question is there a relationship with negative early childhood experience and the development of fibromyalgia? If yes, does treating the trauma help to reduce the pain? Now that's a wonderful question. There's absolutely no doubt that early childhood trauma is associated with fibromyalgia. The explanation for that is not clear at the moment, but early childhood trauma can be dealt with in many ways, and there are many psychological techniques to try to deal with these kind of bad memories, if you like. And there are some clinical trial evidence to show that some of these very unique psychological techniques that deal with previous traumatic memory can help to reduce pain in patients with fibromyalgia. How does outcome with psychological therapies compare with the different types of pain, i.e. neuroinflammatory and nociceptive? Well, one thing that is important to emphasize is that, in fact, the brain has a major part in the processing of pain. And in fact, there are strong evidence that psychological therapy can activate different neuronal pathways that helps to cope with and down-regulate pains. So potentially, psychological-based therapy could improve all types of pain, be it neurological, inflammatory, or nociceptive. Should we be using pain screening tools routinely in clinical practice? Well, pain screening tools is used definitely by our pain specialists in clinical practice. I think the rheumatological community are less familiar with them. We have used them in the research setting. They're readily available and pretty simple to use. So the Pain Detect questionnaire, for example, can be readily downloaded from the internet and is free to be used in clinical practice. So my suggestion for people who are interested is to use the tool in their clinic and see how they get on with using the tool. Do you think we as rheumatologists should be referred to our pain consultants? Well, I think many of my colleagues are already referring the patients to pain consultants. I think the more important issue is selecting the right patient to refer to the pain specialist. We certainly can't refer everybody to our pain specialist. And in most of our patients, there is a mixture of different kinds of pain, inflammatory, nociceptive, as well as neuropathic. I'll give you a typical example. A patient with rheumatoid arthritis may have secondary osteoarthritis as well as a degree of fibromyalgia. So it's important to recognize what are the dominant symptoms in that individual patients and manage it accordingly. And it can be done by a rheumatologist as well as a pain specialist. As access to a clinical psychologist is poor, how can we help deliver psychoeducation intervention in order to ensure behavioral change rather than information? Well, that is a great question. To some extent, we are trying to address that in a recent trial looking at teaching healthcare professionals to deliver cognitive behavioral therapy in patients with rheumatoid arthritis to help to improve their fatigue. And our preliminary experience with that trial is that healthcare professionals can be trained to deliver cognitive behavioral therapy at a group setting. And many patients have reported to us that they're getting benefit from those interventions. Would you advise using a free variable DAS28 PGA without the patient global assessment score in patients with rheumatoid arthritis and fibromyalgia? Well, using a free variable DAS28 score may not help the issue completely. Part of the reason for that is that the patient global assessment score only contributes to a small percentage of the DAS28 score, in fact less than 10%. So removing it is possible, but it doesn't completely address the huge impact of fibromyalgia on disease activity assessment. And as I show you already, patients with fibromyalgia tend to have much higher tender joint count because they have reduced pressure pain threshold, so they're more likely to report pain when you press on their joints. So we only have time for one more question. The question is, if pain is particular problem is there, any diets would help? That is, does anything help? Well, let me try to address the question. If I understand it correctly, is that if pain is a particular problem, would doing anything with the diet help the problem? Well, I think in part it kind of depends on the nature and the severity of the pain. There's very little evidence that diet can help neuropathic pain. For nociceptive pain and inflammatory pain, perhaps you can argue that food supplements such as glucosamine or fish oil may have the potential to reduce a degree of inflammation and therefore pain, but the evidence for that is rather poor. So thank you very much for all your interest. I enjoy your question enormously, and I thank you for your attention, and I hope that in the future you will enjoy more webcasts from this endeavor. Thank you very much.